It's a difficult question because, as Dr. Jean-Jacques said before, you don't have front-to-front data to discuss that with the patient. But in the last 5 years, so many things happen in the melanoma field. They think other news, other effective treatment we have in the next year. So for the patient to be alive is an opportunity anyway. The best thing for them is to have a response to the treatment. Even if I couldn't say with this treatment you can be cured, with this other you can be cured, because I don't have the answer in advance. I can say to the patient, with the treatment you have the possibility to live longer, and you have the possibility to obtain a response, and something can help you. And so I think even this point is important for the patient, because if you look at the patient progressing at the start with immunotherapy, the patient progresses at the start with target therapy, there are a double number of patients progressing with immunotherapy, and they progress now, and you don't have something different now. For patients progressing with the target therapy, that's less, so they live at the start longer, and they could have other treatment, other new drug, other protocol. Some patients also in the past are still living only because they could enter in different study at the right moment. The patient who progressed because there was nothing at the moment are not living now. So this is an aspect I discuss with the patient. Anyway, the patient at the end decide what he prefers to have. Some patients specifically prefer immunotherapy because they feel immunotherapy is a friendly treatment despite the toxicity. There are this feeling. Because it works with the immune system, it works against the tumor by inside. Target therapy is something what directly has a different aspect, but it is less toxic. So all these different aspects enter in the discussion. The majority of the patients, I have to say, they prefer to have a better result, and they obviously want to be cured, but they choose the immediate result if they could choose.
I'm sorry. I would add a few comments. With targeted therapy, it's very hard to stop a treatment. When you stop it, usually the disease is coming back. Some good news is that if you have to stop because of a failure, you can reintroduce BRAF inhibitor after immunotherapy, for instance, after 1 year or 2 years, and you still have a response. But anyway, when you have a response, it's very tricky to stop the treatment. With immunotherapy, it's quite different. In many patients, we can stop the treatment. We don't know exactly what are the criteria to stop the treatment, but we know that patients with a complete response or an early complete response, and even those who are stabilized, we can stop after a few months, and most of them keep their benefit at least for, let's say, a few months or years, because for the moment we don't have more information. This is really an important issue for a patient, the duration of treatment. Of course, if you start a treatment and that's for life, it's quite different if you start a treatment that it's for 1 year, 2 years. So in the general benefit, in the balance, I think these different profiles of immunotherapy and targeted therapy are to be taken into account.
In general, the vast majority of patients with metastatic disease are not cured. So we made progress, but there is room for improvement. So for the vast majority of the patients, there is no real long-term benefit, at least for 50% of patients who ultimately die for their disease. So both in the short term and in long term, there are several factors that a clinician should consider. First, the presentation of the disease, the burden of the disease, the patient preference, the genetic status of the tumor, the LDH level, and the discussion of the duration of treatment. As Dr. Grob mentioned before, there are some exciting data with immunotherapy that we can stop the treatment after 2 years, and in patients with complete response at a median follow-up of 10 months, 91% of the patients maintain the response. So this is part of our counseling with toxicity of immunotherapy and of target agents, and all these information are important when we discuss the ratio of risk-benefit, toxicity and benefit with each patient we see every day in our practice.
Yes, but I would like to say that no more than 10% of the patient immunotherapy reach a complete response. So we have data on no more 100 patients for the study and 100 patients for ARP program in Europe. We have also data that 50% of the patients in complete remission with target therapy didn't recur after the stopping the treatment. And to continue treatment, we intravenous every 2 weeks, every month, and to continue treatment to pills is different thing. So the patient discussed this point, despite that some of them prefer to have an oral treatment instead of intravenous treatment. This is another point. We don't have data on the stopping rule of target therapy, and this is a pity. We don't have in the intermittent course of target therapy. Also intermittent course could be effective as a biological rationale to do it, but we wasn't able to do it till now. So there are a lot of questions still to be answered in this kind of treatment in the field of patient treatment.